Thank you all so much for joining me. My name is Tara Salzberg. I am the owner of Care Compass. I am an independent broker. So what I do is I help people navigate the Medicare process because it is extremely confusing. This is my buddy Truman the turtle. He's my best bud, and you will see him kind of throughout this presentation. He'll pop up and ask questions here and there and things like that. We are in the Weber Advisors building today, of course, and I do have a location here in the Weber Advisors building right upstairs. So most of my clients do come in and see me in person, although I do Zoom calls and phone calls and things if the client prefers as well. But thank you so much for the Weber Advisors team for allowing us to host this seminar here this morning for you. Just a quick little disclaimer, this seminar is for educational purposes only. I do give some examples, but they are not representative of any particular carrier, okay? They are just for sample sake. And so just a quick question to get started here. I've asked this question many times in seminars prior, and I just want you to kind of give me the first thing that comes to your mind when you think of Medicare. And you can go ahead and just say it out loud.
Health insurance.
Health insurance.
Retirement.
Retirement. So when I've asked this in the past, these are sort of most of the answers that I get. Annoying, lack of trust, so-so coverage, government, frustration, it's difficult, overwhelming, confusing, rules, it's complicated. And so it's so funny because as many times as I've asked this question, I only ever hear these types of responses for the most part. I never really hear somebody who's like, when I navigated this process, it was really easy, no problem. Had it all under control, I understood everything. So it's funny because this is what people tend to think about, government and, frustration and confusion. Those are sort of the words that tend to surround Medicare. And so what I like to do is try to make this easier for people to understand. And so at Care Compass, we want to empower Medicare eligible individuals to make educated and informed decisions about their health care. And our mission is to help you find the best plan to meet your needs, budget, and lifestyle so you can focus on your health, not your insurance. So I'm a very big proponent. We talked earlier about how actually I'm an educator by nature. And so I really think it's very, very important that people are making their own healthcare decisions because they're understanding how this process works. So when I work with somebody, I don't just say, here's the plan that's going to fit your needs. I say, what options do we have? And then let's look at those different types of options. And so people are educated about the decisions that they're making and why they're making those decisions related to their healthcare. This seminar today will answer the question, what is Medicare and who qualifies? We'll recognize the different parts of Medicare and their associated costs. We'll understand the 6 main gaps when it comes to Medicare coverage. Learn about Part D prescription drug plans as well as their stages. Understand the enrollment process and enrollment periods. And then we'll learn the basic differences between Medigap plans and Medicare Advantage plans. So we'll talk about those at the end, but I do a much deeper dive into the beyond basics. But we will learn those basic differences today. So what is Medicare and who qualifies? Medicare is federal health insurance administered by the Centers for Medicare and Medicaid Services, also known as CMS, and I will refer to it as CMS sometimes. So if I do say that, that's what I'm referring to, Centers for Medicare and Medicaid Services. Primarily for those who are 65 and older, but also for those who have been collecting Social Security disability income for 24 months, or those who have end-stage renal disease or ALS, which is also known as Lou Gehrig's disease. And so let's start off with just the basic parts of Medicare. There's 4 basic parts to Medicare. A, B, C, and D. Sometimes why Medicare is referred to as the alphabet. So our first one that I want to talk about here is Part A, hospital coverage. And then we'll talk about Part B, which is our medical coverage. We'll flip over and go into Part D, which is prescription drug coverage. So when you think of Part D, think drug. And then toward the end, we're going to save Part C toward the end because it does tend to be the most confusing for people to understand. So we're going to talk about A and B a good bit. And then we'll talk about Part D, prescription drug coverage. And then toward the end, we're going to go back into that Part C, Medicare Advantage, a little bit more because it just tends to be sort of confusing. Part A is our hospital coverage. So when you think of Part A, think of inpatient, if you were to go into the hospital. Part A also includes, though, a skilled nursing facility. So for example, let's say that you go into the hospital and you have some sort of surgery, and then you need to go to a skilled nursing facility after that for maybe some rehab or something like that. Skilled nursing would also fall under your Part A, hospital. Some home health care falls under Part A, some also does fall under Part B, depending on what it is. And hospice care. Hospice care always falls under Part A as well. And then when we think of Medicare Part B, sort of think of anything outside of what we just talked about. So anything really outside of Part A. So outpatient services, think things like doctor's visits, lab work, physical therapy, occupational therapy, preventive services, ambulance, durable medical equipment. And then again, some home health services would fall under Part B, some would fall under Part A. Okay, so Part A, inpatient. Part B is going to be outpatient services, like medical services. And so fundamentally, one of the really important things to understand when we're talking about Medicare is that Part A and Part B together make up what we call original Medicare. And I will refer to that a lot throughout the presentation. Part A and Part B together is known as original Medicare. And that's important to understand, and you'll kind of see as we go through this why it's important to understand that. So original Medicare covers preventive services, actually about 24 preventive services. Annual wellness visits, various screenings such as mammograms, vaccines, diabetes screenings. And so there's quite a list of things here that are covered under original Medicare. But the things that are not covered are going to be things like custodial care. So custodial care would be relating to activities of daily living. So that's going to be things like eating, dressing, bathing, things like that. Custodial care. Original Medicare does not cover that. Does not cover routine dental. Does not cover routine vision or glasses. Original Medicare also does not cover routine hearing exams. They will cover diagnostic exams to determine if there's some sort of issue that needs treatment, but routine hearing exams are not covered under Original Medicare. Original Medicare does not cover hearing aids, cosmetic surgery, acupuncture, most prescription drugs, because that's going to be our Part D benefit, and healthcare outside of the U.S. except in very rare circumstances. So let's talk about the costs associated with Part A and Part B. So again, Part A and Part B, original Medicare. And for Part A, most of us, about 99% of beneficiaries, don't pay for Part A. So if you'll remember, Part A is our hospital. And if you've worked over 40 quarters, or you can draw this from a spouse, so even if your spouse has worked 40 quarters, you will get Part A, what we call premium free. So again, that's going to be most beneficiaries. If you've worked over 40 quarters, so that's roughly 10 years and paid your FICA taxes, you will receive your Part A premium free. So you will not pay a premium for that each month. And then you can see here, of course, if you've worked 30 to 39 quarters, you do have a premium of $278 a month. And if it's fewer than 30 quarters, $505 premium per month. And I should note that they do not need to be consecutive, those 10 years, those 40 quarters. But if you did work over 40 quarters, like most beneficiaries, you will receive Part A premium free. And then our Part B again is our hospital or our outpatient medical services. And Part B we do pay for. In 2024, our standard premium is $174.70. That again is what most beneficiaries are going to pay. So for Part B, the standard premium in 2024 is $174.70. However, there will be some people who have to pay a higher premium for Part B. And this is an example of that bracket. So you'll see if I were single and made less than $103,000, my Part B premium will be that standard bracket. And a couple, if it's less than $206,000, I'm still in that standard category. Okay, but you can see, of course, as that goes up, the Part B premium will increase. And this also does affect Part D prescription drugs as well. There will be an increase on your premium there as well if you qualify for some of these higher brackets. But most people, again, are going to pay that standard premium. And I should note this is based on income from 2 years prior. So if you have had some sort of change in your income, there is a way that you can appeal this, but you must have had some sort of life-changing event, a marriage, a divorce, loss of income producing property, something like that. Okay, so let's talk about these gaps in Medicare. So again, we're talking about original Medicare. So if I were to just have Part A, my hospital, and Part B, which is my medical services, that leaves us open for what I like to call the big 6 gaps. And so what you'll notice here, I know this slide is a lot, and I'm going to actually simplify this in the next slide, but just as a general understanding here, we look at these different gaps here. Our first gap is our inpatient hospital stay. And in 2024, the deductible is $1,632. So that means if I go into the hospital, I'm spending $1,632. So as a reminder, a deductible is an amount that needs to be met before our insurance comes in and helps us at all, right? So if we go into the hospital, we are immediately paying $1,632 before our insurance kicks in at all. Okay, and that's per benefit period. So a benefit period is going to be if you go into the hospital and you're then discharged. If you go back to the hospital within 60 days, you're still in what we call that benefit period. So if you go back into the hospital, you don't have to pay that deductible again because you're still within that 60-day period. But if you go outside of that, so let's say you're discharged from the hospital and you go back 6 months later, you're paying that deductible again. So you theoretically could be paying this deductible multiple times each year. So that's a really big gap. That's one of the biggest ones. So after our deductible is met, let's say we're in the hospital and our deductible is met, we have a co-insurance then. So if we're there days 1 to 60, we don't pay anything while we're there for those 60 days. But if we go beyond that, then we're starting to pay a co-insurance each day, or copay each day, of $408 for days 61 to 90. Now, if we go beyond day 90, we're now into our 60 lifetime reserve days. We have 60 of those in a lifetime. If we start digging into those, we're looking at $816 per day if we go and have a hospital stay beyond that 90 days. Now, I should note that most beneficiaries are not in the hospital that long, thankfully, but it is something to keep in mind. And then we get to skilled nursing. And skilled nursing, again, would be like if you had to go into maybe Encompass Rehab, for example, because you needed some skilled care. Once we get in there, we have days 1 to 20. We don't pay anything for those first days. But if we go beyond that, we're then paying a per day $204. Okay, so you can start to see how these numbers could rack up if you end up in the hospital or in a skilled nursing facility. So those are sort of the gaps on our Part A, our hospital side or our inpatient side. And then we come down to Part B, our medical side. And on Part B, we have a deductible. And so for 2024, that deductible is $240. So on our medical side, we have to meet that $240 deductible. And then after we meet that, generally, as a general rule of thumb, we're paying 20% of all of our bills. So think about if you went in and you had, again, some sort of surgery and you only had original Medicare Part A and Part B, you're going to be responsible for 20% of that cost. Now, excess charges, this is an interesting one. I name it as one of the gaps, but basically what this is that a physician could charge you up to 15% more than the Medicare reimbursement, the Medicare allowable. Now in Pennsylvania, these don't exist. There are not excess charges. They are not allowed in Pennsylvania. But if you were to go and receive care outside of Pennsylvania, theoretically a physician could charge you excess charges if they wanted to. So if you had to go to a specialty hospital or a specialty clinic, for example, a physician may charge you up to 15% more. So this is a nice simple way to look at this. So we have our Part A side, which we talked about, and then we have our Part B side, which we talked about. So on the hospital side, again, we have that deductible, and you can potentially have this deductible more than once throughout the year. And then we have our per day copayment of days 61 to 90, 408, and then again, 60 lifetime reserve days. We get 60 in our lifetime, but if we're digging into those, $816 a day. And then we have our skilled nursing. And then if we get onto the medical Part B side, we have our $240 deductible, our 20% co-insurance for all of our medical services, and then potentially excess charges. So these are some really big gaps. And what we need to figure out is once we go on Medicare and we get Part A and Part B, how are we going to reduce that liability? Because we certainly don't want to be liable for all of these big gaps, right? And so we'll talk about that as we keep going. Let's look at a quick little example of this. Mr. Jones is hospitalized. He's admitted for a 5-day stay and is released with no complications or further treatment. 3 months later, he is readmitted to the hospital for a separate issue. He has a 3-day stay followed by 30 days in a skilled nursing facility. Then he is released. He receives some other outpatient services and meets his Part B deductible. Then he sees a specialist. So Mr. Jones only has original Medicare. He only has Part A and Part B. So let's see how that affected him. So his first stay, he paid $1,632. Okay, so he met that deductible. But then unfortunately, he went back in, I think it was what, three months later? He has to pay that deductible again. Okay, he's in a new benefit period. So those first 20 days in the skilled nursing facility, we didn't pay anything for those, but he was there for 30 days. So we're looking at $2,040 in the skilled nursing facility. He met his Part B deductible, and then he went and saw a specialist. And so remember, 20% of all of your medical services right now if you only have original Medicare. So he is now out another $60 for his specialist visit. So you can see if you only have original Medicare and you don't have some way to cover those gaps, how you can end up with some really large bills. So in this case, Mr. Jones has $5,604 out of pocket. So we'll head back and we'll talk more about that, how we can reduce our liability as we move forward. But let's touch base on Medicare Part D. So Part D, remember, is drugs. So Part D will help you with your prescriptions. There are two ways that you can get your prescription drug coverage. The first way is through a standalone prescription drug plan. The other way is MAPD, and that's an acronym we use that means a Medicare Advantage plan with prescription drug embedded into the plan. Okay, those are the only two ways once you go on Medicare, standalone plan, or you could get a Medicare Advantage where the prescription drug coverage is built into the plan itself. It's embedded in the plan. Now, when you're looking at your prescription drug coverage, there will always be a formulary. And a formulary is basically a list of the prescription drugs that that particular plan covers. So when you're thinking about this and you're aging into Medicare, thinking about prescription drug is really, really important because you want to make sure that whichever plan you choose, your prescriptions will actually be on that plan's formulary. That formulary will have generics and brand name drugs, and it typically will categorize them into tiers, and there'll be different cost sharing on each tier. So generally, there's usually 5, sometimes there's 6 tiers on a formulary. Those lower tiers, 1s and 2s, they're probably going to be your generics. They're going to be really inexpensive. And then as you go into 3, 4s, and 5s, that's when that co-payment is going to be a bit more substantial. Most people will spend more money on prescriptions than anything else in healthcare. Truman asks a great question. I don't need meds, or excuse me, I don't take any medications. Do I need Part D coverage? Yes. Yes, absolutely. So the reason I say that is because I get this question a lot. You know, I have somebody who is overall healthy, they come in, they're not on anything. And what I always tell them is, if something happens, you are going to want that prescription drug coverage, right? If something happens, you'll be very thankful that you have that prescription drug coverage. So even if you're not on something now, let's find a really inexpensive plan that we can put you on so that if you need something in the future, you have that prescription drug coverage. The other thing here too is that you will get a late enrollment penalty from Medicare if you don't have creditable coverage. Okay, so if you go more than 63 days without creditable drug coverage, then you will have a late enrollment penalty. So I always tell people, make sure you have a prescription drug plan. Again, either a standalone plan or prescription drug coverage that's built into a Medicare Advantage plan. And the thing to note here is I'll have people that come in and they're like, well, I use GoodRx and it's cheaper than a prescription drug plan. And that might be the case. You can still use that. Just because you have prescription drug coverage doesn't mean that you have to necessarily use that. You could still use GoodRx or any other place that you can get your prescription cheaper, but you always want to have that plan anyway, just in case you need it in the future. So let's talk about Part D, the 4 different stages. And this is changing. So this is as of 2024. This is how this system currently operates. Now, I'd like to note, and the reason I like to show this is because I have people that come in and they don't understand how these stages work when it comes to Part D. And so what they'll say is sometimes I pay, very little for my medication. Sometimes I go and I pick up my medication and it's significantly more expensive. And it's because it depends which stage you're in. Okay? So a lot of people coming off of group health insurance, for example, or maybe marketplace insurance, you go and you fill your prescription, maybe at the beginning of the year, and you pay X number of dollars for it. Let's just say you pay a $15 copay. 3 months later, you go and you pick up that same prescription, it's still $15. Maybe 3 months later, it's still $15. Generally, that copayment is going to stay the same throughout the entire year. When it comes to Medicare, of course, things are a little bit different and more confusing than that. So first, we start with the deductible stage. And if you'll remember, deductible has to be met before insurance comes and picks anything else up for us, right? So if I have a plan that has a deductible, and my plan's deductible is $545, I have to meet that deductible before my insurance will help me. So this is the first stage. So in this stage, I'm the only payer, me as the enrollee, right? I'm the only one paying here. So what happens is after I meet my deductible, then I enter what's called the initial coverage stage. And in this stage, there's actually two payers. It's me and it's my prescription drug plan. We're both paying in this stage. So in the initial coverage stage, this is really where those co-payments come into play. We were talking about the formulary and how there's a tier, and associated with the tier of my medication is what my copay will be. That's really in this initial coverage stage. So usually I'm paying a pretty reasonable copay in here. Maybe I'm paying, $15 for my medications, for example, or $20 for my medications. Usually pretty reasonable, but it depends on the medication, again, in which tier that medication falls. But what happens in this initial coverage stage, again, it's myself and it's my prescription drug plan that are helping to pay in this stage. And so when the full retail cost of the drugs that I'm on reaches $5,030, that's when I end up into that coverage gap, also known as the donut hole. Okay? And when I say retail cost, I mean that's not just what I'm paying as the enrollee, that would be what I'm paying and what my prescription drug plan is paying. When the full retail cost reaches $5,030, that's how we end up in the donut hole. And the donut hole is not a great place to be. Okay? We don't really want to be in the donut hole because once we reach the donut hole, now we're paying 25% of our medications. And so in the donut hole, we're paying for our medications. Our prescription drug plan is helping us a little bit. And then also the manufacturers are actually required to give us a 70% discount when we're in that coverage gap, in that donut hole. And so when the cost of our prescriptions and we factor in that discount from the manufacturers, that discount kind of acts as a credit, sort of like a credit as if we had paid it. So when our full costs reach $8,000, then we go into the catastrophic phase. And in 2024, once we've reached the catastrophic phase, we as enrollees don't pay anything. We pay $0 in the catastrophic phase. So if you do get into the donut hole, where you're paying 25% of your medications, ideally you're getting out relatively quickly to reach that catastrophic phase. And so the only reason that I like to show you this is because this is the way that Part D currently operates. And again, I have people who come in and they don't understand this, so they don't understand why they're paying such different prices throughout the year for their medications, and their medication costs fluctuate. This is why. It depends on which stage you are in. As I said, this is actually going to be changing. The donut hole come 2025 won't exist anymore. And so I won't dive too much into that, but I do talk about it in the Beyond Basics. We'll talk about how that change could affect you. And so when it comes to Medicare enrollment, some beneficiaries are automatically enrolled while others are not. And so those that are automatically enrolled are going to be those who are collecting Social Security benefits currently or Railroad Retirement Board benefits. And if you've been collecting either of those for 4 months or over 4 months, you will automatically be enrolled in Part A and Part B. And that's really important to know because there are cases where maybe you don't want to pick up Part A and Part B. For example, maybe you're still working. Okay, so just know if you are collecting, you are automatically enrolled. You'll receive your welcome packet about 3 months before your 65th birthday. And again, there are times where maybe you don't want to be enrolled. You have to let Medicare know that you don't want to be enrolled. An example of that would be somebody who is still working, who wants to delay possibly Part B, possibly Part A. It just depends on the individual circumstance. Those who are not automatically enrolled, though, so if you're not currently collecting Social Security or Railroad Retirement Board benefits, you have to actually enroll into Medicare. And so you can do that online. You can call the local Social Security office. You can also work with a local Medicare broker who can assist you with this process. Okay, so let's talk about when to enroll. So we have our initial enrollment period, the general enrollment period, a Part B special enrollment period, also known as a SEP, and then other special enrollment periods. So we'll talk about our initial enrollment period first. This is the 7 months that surround your 65th birthday. So if we're looking here at this example, let's say our birthday is in April. We turn 65 in April. Our enrollment period actually begins in January. So we have January, February, March that we could enroll. Now, if we enroll in January, our coverage will still become effective on April 1st. But we can enroll in January. We can enroll in February. It will still become effective April 1st. We could enroll in March. Still becomes effective April 1st. Always becomes effective on the first of the month. Now, if we get into our birthday month of April and we enroll in April, then our coverage doesn't start until May. And if we enroll in May, our coverage starts June. And if we enroll in June, then our coverage would start in July. Okay, so it's always the 7 months that surround your 65th birthday. Now, there is one little caveat to this. If you do have a birthday that's on the first of the month, does that affect anybody? Okay. Well, if you do have one that's on the first of the month, basically you're treated as if your birthday is the month before. So in this example, if our birthday was April 1st, this would be March, and we'd have December, January, February, March, and then April, May, and June would be our enrollment period. So everything sort of, that timeline just moves up 1 month. Now, if we miss our opportunity, then we do have what's called the general enrollment period. And the general enrollment period I like to call the missed the boat enrollment period. This is if I miss my initial enrollment period, I do have another opportunity each year that I can enroll in my Part A and my Part B, and the coverage would begin the first of the following month. But just be aware, if you miss your initial enrollment period, you could potentially have a late enrollment penalty. Now, this only really starts to take effect if you go for over a year without having Part B, but there is a late enrollment penalty, and it's a lifetime penalty. So just be aware. Want to make sure that you're aware of your enrollment periods and when you can initially enroll. And down here is just an example of what that would look like if I missed my initial enrollment period and had to go with my general enrollment period, and I missed it for 2 years. I'm now paying almost $35 extra per month in premium. Part B, special enrollment period. So this would be for somebody when you retire or lose group health coverage. You actually have an opportunity where you can pick up Medicare once you lose that health coverage. There would be no late enrollment penalty, but you must have creditable coverage through your own or a spouse's current job. So what is creditable coverage? That is coverage that is deemed as good as or better than Medicare. And you usually receive a notice from the carrier in September if you have health insurance through work. It will tell you that you have creditable coverage. But essentially, when you retire, you have a Part B special enrollment period where you can pick up Part B without any late enrollment penalty. You have that opportunity as long as you've been holding creditable coverage through your work or your spouse's current employment. Current employment is really key there, though, because generally coverage that is not through a current job, like COBRA, retiree health benefits, or the marketplace, those are not considered creditable coverage. Other special enrollment periods where you could potentially enroll would be if you lose Medicaid status, if you're released from incarceration, impacted by a natural disaster. There's also a 5-star special enrollment period in our area where you could move into a plan that has a 5-star. That gives you a special enrollment period. But generally, if you're working with somebody, or if you're just coming, to something like this, you're becoming educated and understanding what your options are and when you need to enroll. But you could also work with somebody to help you through all of this process and the enrollment to make sure that you don't miss your enrollment period. Then each year we have what's called the annual enrollment period, and you're probably inundated with information during the annual enrollment period. You see TV ads, you're getting stuff in the mail. This is a big deal because it's your one-time opportunity every single year where you can look at your plan and you can make changes. And I always tell people, make sure that you look at your plan. Even if you've been satisfied with the plan that you have, you should get what's called an annual notice of change. And it will tell you any changes that are happening with the plan that you're on. So even if you're completely satisfied, at the very least, make sure that you know what those changes are, because those changes may affect you. But I do tell people, I say, always come in annually and let's look at your plan, because your needs may have changed, some doctors may have changed, your prescriptions may have changed, and also the plans themselves will change. So you want to make sure that you're taking a look at this every year. This is basically an opportunity where you could switch to another Medicare Advantage plan. You could switch from original Medicare to a Medicare Advantage plan, or you can join, drop, or switch to another Medicare drug plan if you now have original Medicare. Now, I realize we haven't talked too much about Medicare Advantage plans yet, so some of you are probably like, I don't even know what that is. We're going to get there. We're going to talk about that. But annual enrollment period is really important, and again, this is every year you have this opportunity to look at your plan. And then we have what's called the Medicare Advantage open enrollment period. And so this would be for anybody that is currently on a Medicare Advantage plan. So from January 1st to March 31st, if you have a Medicare Advantage plan, you could theoretically switch again. So you have that annual enrollment period from October to December, and then you actually have January 1st to March 31st if you have a Medicare Advantage plan where you can make another one-time switch. Okay, it's only a one-time switch, but you do have that opportunity. So for example, let's say that you changed your Medicare Advantage plan during that annual enrollment period in October, and then you have second thoughts. This gives you an opportunity to kind of make one final decision for the rest of that year. So let's go back to that example with Mr. Jones. So you'll remember that he only had original Medicare. So he only had that Part A and Part B. And so his estimated costs because of that was over $5,000. And so how can we reduce our liability? There's two ways. Once we have Medicare Part A and Part B, there's two ways that we can decide to take Medicare, okay? Or reduce our liability when it comes to Medicare, I should say. So our first option is what we call a Medigap plan, also known as a Medicare supplement. They're the same thing, they're used interchangeably, Medigap or Medicare supplement. And I like to call that option 1. The other option, option 2, is a Medicare Advantage plan. So let's talk first about option 1, which is called a Medigap plan. Now again, you will notice you have to have Part A and Part B to enroll in option 1 or 2. So for most of us, Part A, if you'll remember, is premium free. Most of us aren't paying for our hospital coverage, our Part A. Part B, though, our medical coverage, we are paying, generally $174.70 each month. That's our premium for Part B. So we have Part A and we have Part B. Now we're ready to decide, okay, what makes sense here, a Medigap plan or a Medicare Advantage plan? So if we talk about the Medigap side, we have original Medicare, which you'll remember is Part A and Part B, right? And so in this option, we are sending our premiums to Medicare each month. And then in turn, when we need help, when we need our coverage, Medicare is the one. Original Medicare is the one who's helping us with that. They're the ones who are helping to cover our costs. Now, if you have original Medicare, you need somewhere to get your prescription drugs. So you have to add on a prescription drug plan. So in this case, when we take original Medicare, we need to have a standalone prescription drug plan. And then that's where our Medigap plan comes in. Because again, we have these really big gaps in original Medicare. We want to make sure we cover them somehow. If we add on a Medigap plan, that's how we're going to reduce our liability in this case. So I like to think of a Medigap plan or a Medicare supplement as a pay upfront type of system. So I'm paying a premium each month to have my Medigap plan. Now I'm going to pay a good amount each month to have that plan. Okay, so they can be expensive. But I like to consider it a pay upfront system because I'm paying that premium and I know that each month I'm really not going to have to deal with co-pays or co-insurances or anything like that. Once I meet my deductible, $240, everything else from there is going to be covered for me. So I'm paying upfront to have sort of that peace of mind of knowing that my Medigap plan is going to cover or supplement everything that original Medicare doesn't cover for me. Now again, when we take this option, we have to have a separate drug plan. So this would be where we would take our standalone prescription drug plan. And then we can add on a Medigap plan. Now I should tell you, there's no penalty if you don't take a Medigap plan. I don't recommend it because of Mr. Jones's case, but you don't theoretically have to take one. So again, if we look at those gaps that we talked about, a Medigap plan will basically help to get rid of some of these gaps. So if I had the most comprehensive Medigap plan that's out there, which right now is a Plan G, that would cover that gap. So I wouldn't have a deductible. Okay? Or rather, I should say, that Medigap plan would have helped cover that. It would cover this. My Medigap plan would come in and cover this. My Medigap plan would not cover my Part B deductible. I have to pay that. But it will cover this. So if I go in, again, that surgery that we talked about, maybe I have back surgery, original Medicare will cover that 80%. That 20% that we talked about I would be liable for, my Medigap plan is going to cover that for me. And then those excess charges. Let's say I go out of state and I end up having 15% charges from a doctor. Medigap is going to come in and cover that. So I like to think of a Medigap plan as covering these gaps, like plugging the hole in the ship. And again, I dive deeper into this in Beyond Basics. If you're interested in that one and want to know more about Medigaps versus Medicare Advantage plans, we take a real deep dive into pros and cons and all of those different things in that one. So now on the other side, we have what's called a Medicare Advantage plan. Medicare Advantage plans are also known as Part C. So far we've talked about Part A and we've talked about Part B, and we talked about Part D, prescription drugs. Medicare Advantage plans are Part C. Medicare Advantage equals Part C. And so in this case, it operates a little bit differently. In our last case, when we were talking about original Medicare and a prescription drug plan and a Medigap plan, this operates a little bit differently. So I still have to pay my Part A, or excuse me, most of us won't pay for Part A, but I still have to pay my Part B premium. Remember, we have to have A and B, okay? So I'm taking my premium of $174.70 each month, and I'm still sending it to Medicare, but what's happening is the federal government is actually handing that off to a third-party beneficiary. Okay, so think of in our area some of these big carriers. That's them. They are then administering our benefits. So when I go in and I need something, if I need some sort of medical service, it's not Medicare now that's helping to pay my bills. It's actually a third party that's administering my plan. So these plans, these Medicare Advantage plans, have to provide at least the same level of coverage as original Medicare. So they have to be at least as good as Medicare Part A and Part B, because that, of course, is original Medicare. It will still give all the parts of A and Part B benefits. And then there's oftentimes a lot of extras. So think dental, vision, hearing. And then in many cases, I think we talked about prescription drug coverage. Medicare Advantage plans will often have prescription drug coverage built into them. They're embedded into the plan. So I like to think of them as sort of this box, okay, where you have your hospital coverage, you have your medical coverage, you have your embedded prescription drug coverage, you have your extras, dental, vision, hearing, in some cases a gym membership. All of those things are sort of in this one nice clean box for us. We have one policy. Now, if you'll remember on a Medigap plan, we had a prescription drug plan. If we wanted dental, vision, hearing, we'd have to add that on as a separate policy. Right? So this kind of takes everything and incorporates it into one plan for us. Unlike a Medigap plan, which I said was sort of like, I like to think of it as a pay upfront system, this is more of a pay-as-you-go system. This will operate much more similarly to a group health plan, for example, when you were on a group health insurance. You were paying co-pays and co-insurances as you utilized your plan. This operates in a similar manner. Okay, so you're paying, maybe you pay $30 when you go to see your a specialist, for example. And so when we're thinking about those 6 Medicare gaps, a Medicare Advantage plan can also help to reduce the liability. But in a Medigap plan, you'll remember I kind of said, if I have my Medigap plan, it's going to cover these holes, right? Or these gaps. With a Medicare Advantage plan, I like to think of them, in most cases, they usually don't cover the gaps entirely, but they reduce the gaps. So as an example, let's say instead of original Medicare with a Part B a Part A deductible, maybe I have a plan that has a per stay benefit when I go to the hospital. So when I go to the hospital, I pay X number of dollars for as long as I'm in there. And so it will reduce these. So lots of considerations here. when you're thinking of a Medigap plan versus a Medicare Advantage plan. And so these are some of the questions that people don't really know that they should ask themselves. So of course, budget, but am I healthy overall? Any chronic conditions? Am I okay with copays and coinsurances? Do I travel and want portability of my plan? What prescriptions am I taking and are they covered? That's a really big one. That's one of the first things that I do when I have a client come in is I look at the prescriptions. Okay, because we want to make sure we put them on a plan where their prescriptions are going to be covered. What doctors do I see? How often do I go? Do I want an HMO or a PPO or no network at all? Now I realize we didn't talk about HMOs and PPOs and all of that. Again, that's a deeper dive in the Beyond Basics where we really talk about networks a lot more. Do I anticipate any upcoming surgery, therapy, durable medical equipment? And will I utilize the extra benefits? If I have dental, vision, hearing, silver sneakers, any of those things, will I actually utilize those benefits? Do they mean anything to me? And so this is very confusing. But there are options out there of people that can help you navigate this process. And so that is what I do. Again, I'm Tara. I'm the owner of Care Compass. I also am a licensed insurance broker. And the benefits of working with an independent broker is that there's no cost. There's no cost to working with a broker and having somebody assist you with this process. As an independent broker, I am contracted with multiple plans, multiple carriers. So essentially, I have a local knowledge of the space in which I can tell you, I always laugh because I'm like, you could call all of the individual carriers yourself, and you can drive yourself crazy if you want to, but I do this every day. And so I know some of the pros and cons of different carriers in our area. And then, of course, as I mentioned, I'm located right here in the Weber Advisors building in Duncansville. So I'm available for ongoing support as needed. So once you get onto your plan, if you have any questions or things like that, I am available to answer all of those. I'm sort of your Medicare advocate, if you will. So these are the big mistakes that I see when people are transitioning into Medicare. First one is listening to a family or friend. And I always put that one first because I get kind of both sides of the coin here. I have somebody that comes in and they say, Medicare Advantage plans stink. My cousin had one and she doesn't like it. And I always argue, I say, listen, just take that with a grain of salt, because what is probably happening is most likely it's not the plan. It's actually just that plan is not meeting your cousin's needs, right? And so the plan is only going to be as good as how well it meets your needs. It has to meet your needs in order to be effective. So either way, even if somebody tells you something's great or something's awful, usually it's just that their individual needs are going to be different. They have to find a plan that's going to match those needs. Enrolling in Part B when not needed. Remember, we talked about some people are automatically enrolled in Part B. I had somebody come in. He was automatically enrolled because he was collecting Social Security. He was automatically enrolled in Part B. Well, he's still working. He still has creditable group coverage. So he ended up picking up Part B without realizing it, and he never told Medicare he didn't want Part B. So now he's paying that premium. Not paying your Part B premiums. I've seen this too, where somebody just lets their Part B lapse. It's fixable. It's a fixable problem. It's just that it creates a real headache. There's a lot of ways we can avoid headaches, and that's what we're trying to do. But I have seen that. Not considering future healthcare needs. That's that example of Mr. Jones, right? So he wasn't thinking about if all of these things, now he had really bad luck, right? But he wasn't thinking about what might happen if he goes to the hospital, ends up in a skilled nursing facility. Missing enrollment deadlines and ending up with late enrollment penalties. Not understanding your own needs. Not checking networks, doctors, prescription drug coverage. Always want to check those. Not reviewing your coverage annually. We talked about why that's so important. And then not seeking guidance. Like I said, there are people that can assist with this process. And so at Care Compass, basically what we do is Medicare education, just like we did this morning. Plan education and comparisons. We help with prescription drug coverage, enrollment assistance, those annual reviews that we talked about. And then we're here to provide ongoing service and support to you as you need it.